Time-restricted eating and eating disorder risk. Necessary cautions. The rise of time-restricted eating as a mainstream dietary approach has occurred against a backdrop of increasing eating disorder prevalence, particularly among young adults. This convergence raises critical questions about whether temporal eating restrictions might trigger, exacerbate, or mask disordered eating patterns. The psychological relationship between dietary rules, food preoccupation, and eating pathology demands careful consideration before recommending time-restricted approaches, particularly to vulnerable populations. The potential benefits must be weighed against real risks of harm to psychological well-being and eating behavior. Time-restricted eating shares concerning similarities with eating disorder behaviors. The rigid timing rules, preoccupation with eating schedules, and guilt associated with eating outside designated windows mirror psychological patterns seen in restrictive eating disorders. For individuals with predispositions toward rigid thinking or perfectionistic tendencies, known risk factors for eating disorders, time restriction may provide a socially acceptable framework for expressing underlying restrictive urges. The quantifiable, rule-based nature of time restriction can prove particularly appealing to individuals seeking control through dietary manipulation, a core feature of anorexia nervosa and other restrictive disorders. The distinction between health-motivated behavior and disordered eating becomes murky with time-restricted eating. While some individuals implement time restriction as part of balanced health strategies, others use it as progressive restriction that escalates over time, narrowing windows, obsessing over exact timing, experiencing anxiety about schedule deviations. These escalation patterns may indicate evolving eating pathology that warrants clinical attention. Healthcare providers and individuals themselves must remain vigilant for warning signs, including social isolation to maintain eating schedules, persistent food preoccupation beyond hunger, anxiety, or distress around timing flexibility, and escalating restrictiveness over time. Existing research on eating disorder risk with time-restricted eating remains limited but concerning. Some studies document increased eating disorder screening scores and symptoms in subsets of participants, particularly those with prior eating concerns or weight cycling histories. The causality remains uncertain. Time restriction may trigger disorder development in vulnerable individuals, or those with subclinical eating issues may gravitate toward restrictive approaches. Regardless of direction, the association warrants caution in populations at elevated baseline risk. Binge eating represents another concern. Extended fasting periods can trigger compensatory overeating in susceptible individuals, particularly when combined with restrictive calorie targets. The feast-famine pattern created by time-restricted eating may reinforce binge-restrict cycles rather than establishing normalized eating patterns. For individuals with binge eating disorder or bulimia nervosa, time restriction may paradoxically worsen symptoms despite the structured framework's superficial appeal. Young adults and adolescents merit special consideration given their elevated eating disorder risk and documented susceptibility to diet culture messaging. The promotion of time-restricted eating through social media, often by influencers without medical credentials, reaches adolescent audiences particularly effectively. The framing of time restriction as an easy health hack obscures potential psychological risks for developing minds and bodies. Healthcare providers working with young populations should screen carefully for eating disorder symptoms before considering any time-restricted approaches, and perhaps default to discouraging such practices in adolescent populations. The clinical recommendation for individuals with eating disorder histories appears clear. Time-restricted eating generally represents an inappropriate intervention that risks relapse or symptom exacerbation. Even for individuals in sustained recovery, the rule-based restriction and food timing preoccupation could reignite maladaptive patterns. Alternative approaches to metabolic health that emphasize flexibility, intuitive eating principles, and non-restrictive frameworks prove more appropriate for these populations. For individuals without eating disorder histories considering time-restricted eating, Maintaining awareness of psychological warning signs remains essential. Healthcare providers should inquire about psychological impacts during follow-up, specifically assessing for increased food preoccupation, anxiety around timing, social withdrawal, and escalating restrictiveness. The presence of any such patterns should prompt discontinuation and potential mental health referral. The field requires greater integration of eating disorder screening into time-restricted eating research and more explicit acknowledgement of psychological risks in both scientific literature and popular communications. Metabolic optimization never justifies psychological harm, and dietary interventions must be evaluated through comprehensive lenses that include mental health alongside physical outcomes.